for long periods of time. If we do all those things, they usually do okay. Very occasionally and very occasionally only do we end up pacing them. And by the way, some of the ones we pace continue to have syncope even after the pacemaker. It's not a particularly effective therapy. It's a very scary ECG. But pacing really isn't the answer.
You said something about neuronal vagal syncope. It's very interesting. Clinically, we see a lot of cases with the attacks of unconscious spells. So when we investigate neurologically, cardiologically, everything will be normal. Probably a course of anti-epileptic therapy, it's called as temporal lobe syncope. Type 3 of temporal lobe epilepsy falls into neurologically mediated cardiac syncope. So there is very interesting phenomena which is noted in clinical practice. A lot of cases, young people come with the attacks of unconscious spells and suddenly they become all right. Probably they fall into this category of neuronal mediated vagal syncope. That's very interesting phenomena. We treat with them with carbamazepine, a full 1, 2, and as like any anti-epileptic treatment. They do very well, they respond very well, and they respond also.
So there are a couple of randomized trials of drug therapy in neurally mediated syncope. So far, all of them have been negative. But there's one going on now with midrodine, amotine, and there's been a small one already with midrodine, which has been positive. So there are other things we can do besides pacing in these neurally mediated syncope.
Even in Australia, there was a truck driver who came involved in 3 accidents. On the road, was on the regularly mediated, but he'd gone through red lights a couple of times and crashed into multiple other vehicles and caused a couple of deaths with the last one. And so I think your vocation is also important when you consider the need for pacing in someone even with neurocardiogenic syncope.
Well, I'm not sure I agree. I'm not sure I agree because I'm not sure that I would want this guy driving a truck even after a pacemaker.
No, he was diagnosed after the third episode, and the license was obviously cancelled.
Yeah.
He continued to have
well, I guess what I'm saying though is that the vocation is probably not important because I don't think you want this guy driving a truck anyway, even after you've given him a pacemaker. I think you have to make the decision about pacing based on whether you're likely to help his symptoms. But the vocation, I mean, you're absolutely right. I don't want this guy driving a truck on my streets.
Tilt table test, in case of syncope, I mean, what are the indications? Is it really useful?
What I missed the first part of the question.
Tilt table test.
I can answer that simply. The question is tilt table test in syncope? No. History. The first step is history, the second step is history, the third step is history, and the fourth step is history. If you can't make the diagnosis based on history and the look for structural heart disease and other things, obviously aortic stenosis, pulmonary stenosis, hypertrophic cardiomyopathy, all those things, tilt table test is unlikely to get you to the next step because it is an imperfect test when the single most important test you've already done, which is history.
Thank you, sir. I now request Dr. Jay Prakash to felicitate our speaker, Dr. Martin Green. I request Dr. Martin Green to hand over the certificates to the chairpersons.
The chairpersons for the next topic are Dr. Rajpal Singh, Consultant Electrophysiologist at Apollo Hospital, Bangalore; Dr. Muhammad Ashraf, Associate Professor of Medicine at Father Muller Medical College, Mangalore; and Dr. B.M. Venkatesh, Professor and Head of the Department of Medicine, Father Muller Medical College, Mangalore. I request the chairpersons to kindly occupy their seats. Our next topic for the day is Long-Term ECG Monitoring Techniques, Types and its Clinical Utility by Dr. Yogesh Kothari. I invite you, sir, onto the dais. I invite Dr. Yogesh Kothari onto the dais for the session.
There he comes. Dr. Yogesh Kothari did his MBBS from Ambedkar Medical College in Bangalore, did his MD from KMC Manipal, and has done his DNB cardiology from the Vijay Institute Cardiac Center in Chennai. He has got experience in EP at the KC Cherian Heart Foundation, and he practices as a senior electrophysiologist at Apollo Hospital. He visits quite a few places, as I know, at St. John's Rajarajeshwari Hospital and VIMS in Tirupati. Yogesh, the floor is yours.
Uh, Good morning to everybody. It's been a wonderful experience here at Mangalore, and I thank the chairpersons and I thank the organizers for giving me this opportunity and to speak on a very important topic, which is basically long-term ECG monitoring. Some of these have already been touched by previous speakers, and I would like to go to the presentation directly. What are the routine things? What do we routinely do? Routinely we do a 12-lead ECG, we do a rhythm strip, and we do a 24-Holter monitoring for arrhythmia diagnosis. But are they enough? That is the question we always ask. And we very well know that they have very poor sensitivity, which ranges from 5 to 15%. They have a high specificity. If you find an abnormality in the ECG, or if you find an abnormality in the Holter, it is good because it has a very high specificity. But most often than not, you would miss an abnormality, and it will be most of the time very normal, and you would be left to answer the question whether I am normal, then why am I getting all these symptoms? And that is the question which we need to answer by a more sensitive test. And various electrical events in the heart are always intermittent, they are episodic, they are very short lasting. If you talk of a palpitation, the palpitation lasts for 15 seconds, 30 seconds, sometimes 3 minutes, 5 minutes, very short lasting. And by the time the patient reaches the hospital or a nearby clinic, his symptoms are already gone and the ECG has already become normal. Unlike ischemia, where you will have telltale signs of ischemia, where you will have ST depressions and other things. But in an arrhythmic symptom, most of the time the presentation ECG will be normal. And patients keep having these symptoms and keep suffering from the symptoms. And between events, they are always frustratingly normal. What are the extended long-term ECG recordings that we have? We have patient-activated or event recorders. These can be either automatic or continuous loop recorders. They can have external these can be external in the form of a short-term or an external loop recorder, wherein you put the patient on a small device which by telemetry sends the impulses to a central recording system, and from there the ECG can be analyzed. Or you can have a long-term implantable loop recorder which, like a pacemaker, can be interrogated. And the utility of these long-term recordings is basically in episodic symptoms, and the choice basically depends on the frequency of symptoms. If you have symptoms which are more frequent, say happening once in 3-4 days or once in a week, you can at least put an external loop recorder. But if the symptoms are very far-spaced, then you may need to put an implantable loop recorder. The important thing is it has a good diagnostic yield, and this is to show you the routine 12-lead ECG and the rhythm strip and the Holter are always suboptimal. What would be ideal is a more permanent recorder, which is not possible. The other options we have is either an ELR or an event recorder, and then an ILR or an implantable loop recorder. As one moves from the left to the right side, the diagnostic yield improves. These are the various recording systems. This is a standard Holter which we all aware. This is an event recorder which is patient activated. The patient activates whenever the event has, and when the event is activated, immediately it freezes the ECG which was just before the activation point. About different event recorders have different durations of freezing the recording, and then it continues the recording for a finite duration after the event. So from the point of pressing of the event, it records the ECG before and after that. And then you have automatic external loop recorders which keep continuously recording and sending the data, and that data gets transmitted to a central server where it can be analyzed. Then you can have implantable loop recorder. This is a small device which can be implanted in the chest, just like a pacemaker, and it has a battery and life, and it can be interrogated by telemetry just like a pacemaker is interrogated, and it can give you a recording up to 2 to 3 years, and then we can make a better diagnosis in these patients. Why is it important? Because we know that all these symptoms like palpitation and syncope are very common, and they are one of the most common reference to an electrophysiologist. The most common reference to an electrophysiologist is either a syncope or a palpitation. And we know that palpitation is a very common symptom in the community. And if you look at Framingham data itself, there is almost a 23% incidence of syncope in a 10-year period in elderly who are above 70 years. So it's a fairly common symptom of presentation, and it really needs evaluation most of the times, and you need to do multiple levels of evaluation before you can actually come to a diagnosis. The diagnostic yield is about 2 to 11% in ECG, and by adding an Holter you only increase the diagnosis to say up to 14%. So between ECG and Holter you just make diagnosis of syncope in only 14% of the patients all put together. And by adding an external loop recorder and by adding an implantable loop recorder, you can improve this diagnostic sensitivity. That is the reason why an implantable loop recorder or an external loop recorder monitoring is very important. And the probability of finding arrhythmia is related to the duration of the monitoring, and the ideal duration is, as I told you, depends on the patient-to-patient subset. Just to show you that sometimes you have patients who have recurrent syncope and we don't pick up the diagnosis so many times, and this is one such patient who presented with syncope, but the ECG and the Holter was normal, and you can see a episodic AV block which developed in this patient, and that's obviously the cause of the symptom, and the patient can appropriately be treated with a pacemaker. So that is the importance of having a extended recording like a loop recorder or an implantable loop recorder. This is a 39-year-old female who presented with 2 episodes of syncope to us, and she had underwent external loop recorder, and you can see here, as Martin sir had pointed out, there is no slowing of the sinus, and suddenly you see without slowing that there is a 2:1 AV block which has developed intermittently, and these are the kind of patients that you can really benefit by making a better diagnosis in such patients. This is a 24-year-old female with primary pulmonary hypertension, and obviously we all know that patients with primary pulmonary hypertension, when they have palpitation, they can sometimes have VT, or they can sometimes have atrial arrhythmia because of heart failure and right heart failure, right heart dilatation. And you can see that though the patient has a lot of VPCs, but her actual palpitation may be actually atrial tachycardia. So you don't need to panic, and probably antiarrhythmic therapy is what you would treat her. But if the patient had an episode of VT, then you will be more concerned in such a patient. So it helps you in making a better diagnosis for your patient, and especially when they have presentation with palpitations or various other symptoms that they may present. This is a typical external loop recorder report, where they will give you a date-wise tabular column and what are the events that were seen, whether they had seen any events, and the diagnostic, and with that they will be sending the recordings and the sample ECGs, and you can ask for additional ECGs depending on your suspicion and things like that. This is a patient who had undergone a ELR for atrial fibrillation, and you can see multiple episodes of atrial fibrillation here. Some of them are auto-analyzed, and some of them are patient triggered. When patient had the palpitation, the ECG was triggered and it was captured, and it shows paroxysmal atrial fibrillation. Sometimes we can use these external loop recorders for follow-up of the patient. So if the patient had atrial fibrillation, once the patient was treated, if the treatment was inadequate, still patients had episodes of AFib, then you increase the dose and monitor the patient again. And also you can monitor the pro-arrhythmic effects of various antiarrhythmic drugs. So even for that purpose, the external loop recorder may be very helpful. So this patient had actually in the past 3 to 4 episodes of atrial fibrillation. He was very symptomatic, and then he was started an antiarrhythmic drug, and it is in an extended 1 week period to 10 days period, the patient was done on antiarrhythmic. He had done a loop recorder, and then now we realize that there were no episodes in the 10 days. So especially atrial fibrillation paroxysmal, whether your therapy is effective, whether your ablation is effective, whether there are any pro-arrhythmic effects of the drugs, all these things can be better made out on an extended loop recording rather than just a static ECG or a Holter. So these are the other benefits in atrial fibrillation. Sometimes we insert a loop recorder called as insertable loop recorder, which I had shown you earlier, wherein a small pen-like device is inserted in the subpectoral pocket, just like a pacemaker, and these patients can then be monitored for a much, much longer period, even up to 2 years they can be monitored. And these such episodes can be seen very well, and with the external loop recorder, you will get a complete ECG recordings, and if there are any pauses or any events, they can be easily picked up, because the patients, usually if you see many of the syncope patients, they will come have syncope once in 2 months, once in 3 months, and in such patients, even if you do an extended loop recorder which records only for 7 to 14 days, you may not pick up the diagnosis. So in patients who are symptomatic, they have had falls, they have had injuries, but you really don't know what is the cause of diagnosis, and such external loop recorders will be, implantable loop recorders will be much more helpful in such subset of patients. This is a patient who had syncope with diagnosed to have VT. So if you have unexplained syncope, this was one of the trials. They had randomized 30 patients to routine testing and 30 patients to implantable loop recorder. And you can see that 50% of the patients were diagnosed, and after that, after ILR, if they were subjected to further testing, only additional diagnostic yield was only for one patient. They had made some diagnostics by EP study. But if you look at the conventional testing, only 6 patients were diagnosed, and when ILR was added to them, another 8 patients were diagnosed. So the diagnostic yield has improved tremendously with the ILR, and after ILR, most of the diagnosis can be made, and no additional yield after an ILR is seen. So this clearly points out the value and the benefit of an implantable loop recorder. And after the history and physical examination, as Dr. Martin pointed out, that's the most important thing which gives you most of the diagnostic output. The next most important diagnostic output is from the implantable loop recorder, which is about 40 to 50%. So these two comprise the maximum yield of diagnosis as far as syncope goes, and all other things are only contributory. Like if you look at the head-up tilt test, though the head-up tilt test says 27%, that is actually can be picked up by the history and physical examination itself. It's not that it is an additional yield. So that's what we need to realize. This just actually initially we were, as per the company guidelines, we are putting the external loop recorder in the 4th space. Then presently we implant in the same pocket, and then if the pacemaker is required, we can explant that and then put a pacemaker. So our initial days we are putting it in a different space, because the company recommendation was a 4th intercostal space where you get the best ECG vector and other things. So then later we realized that even in the subpectoral pocket we get an equally good ECG, and hence once we get a good ECG in that region, we first measure the ECG wave on the ELR. They have a strip which tests the ECG size, and once we get a good ECG size in this pocket itself, we implant it in the same place rather than because it avoids two incisions for the patient when you are explanting. This is just another 83-year-old lady who presented with history of syncope, and this is a patient with ventricular tachycardia. And so these are all the benefits of making the diagnosis. So in a more long-term recording, you can pick up a lot of things, So symptoms. So based on the symptoms of palpitation, when do you do external loop recorder, or what are the? So you can have a non-looping ELR which is patient triggered, or an event recorder. So because palpitation, patient is not lost consciousness. Most of the time palpitation, patient is fully conscious, fully aware of what is happening, and they can activate the event recorder. And once they activate the event recorder records the ECG before and after the activation. And if it is syncope, you can have a continuous looping ELR where it is automatically recorded. And if the episodes occur daily, then you can have a Holter, and you can have a real-time continuous telemetry like in an ICU setting or anywhere. So if it is continuous. If it is syncope, if the symptoms occur regularly, then you can have a telemetry device like an external loop recorder. You can have an external loop recorder which can be connected. But if the patient has syncope which is very widely spaced, more than 1 month apart or more than 3 months apart, then you can have an insertable loop recorder. So the frequency of symptoms is the most important criteria as to what device you would select. routine recordings like ECG have very poor diagnostic yield, especially in episodic arrhythmias and episodic heart blocks. Extended long-term recordings are available and can be selected based on the indication. They are very valuable and have a very high diagnostic yield and are very useful for monitoring therapy also. Syncope, though relatively infrequent, has significant morbidity for the patient and implications for the caregiver, and these devices are particularly useful to unmask the causes of syncope in syncope of unknown origin. Syncope, pre-syncope and palpitations are the most common symptoms in the electrophysiology referral, and care must be taken to rule in or rule out a particular diagnosis, and many factors yield different diagnostic yield, and we know that an extended recording like an extended loop recorder or an implantable loop recorder give a much higher diagnostic yield as compared to the conventional Holter. With this, I would like to thank for the patient hearing.
Thank you, Dr. Yogesh Katari, for a wonderful presentation. We would allow 1 or 2 questions from the audience.
Loop recorder. But there is no comparison between, sorry, not external loop recorder, ILR. There is no comparison between the ELR and ILR. And the second thing is, nowadays the people are not choosing the ELR. Why is the reason? What is your clinical experience comparative with these two devices?
Definitely, diagnostic yield of the ELR is much higher than the Holter, but it cannot be as good as the ILR. The ILR gives you a much bigger window for your diagnosis. It gives you a window of almost 2 years, whereas the ELR, depending on the type of device, it gives you 1 week, 2 week duration, depending on the different devices. And some of the event recorders can be given for 1 month, especially if you are diagnosing palpitation. You can have event recorders which are much more simpler, which can be plugged on and whenever they have a symptom, and they can be given for a month or so, and they are much more easier for event recording. But when it comes to syncope, ILR or a continuous ELR, which is a continuous loop recording, is always better, because sometimes when the patient has a syncope, either there may not be anybody to activate the event, or the event may be missed by the time the patient recovers. So that is the main difference between the two. And the diagnostic yield would depend on the frequency of symptoms. Just like Holter is not enough for an infrequently occurring symptom, similarly, if your symptoms are occurring say once in 3 months, even a ELR will not be sufficient. You need to look at the symptom duration of the patient, the frequency of symptoms.